It's been questionable all morning, so I'm going to give it my best shot. Good morning, everybody. My name is Courtney Collins. I am a assistant professor at Ohio State University, and I'm here to talk to you about hernias as a chronic disease. Not super relevant for this, but I do get salary support both from the American College of Surgeons and from the NIH and NIA. So this talk is about something that I think when we all really look deep inside ourselves, we actually already know, even though it's something we don't always like to talk about, which is that hernias are really a long-term issue. You know, as much as we see our patients in the office and we sell, our repairs as, one and done, hour-long surgery, don't lift anything heavy for a few weeks and you'll be fine. I think we all really know that hernia disease is something that affects people for a long period of time. Now it's gone again. So today I'm going to go through a few things. One, I'm going to talk about the definition of what a chronic disease is and explain why I think ventral and inguinal hernia disease is a chronic condition. And then most importantly, I want to talk about how and why this should affect the way that we treat our patients. So when you look at what a chronic disease is, the definition from the CDC is that a chronic condition is something that lasts at least 1 year or more, and it requires ongoing medical attention, affects limits activities of daily living, or both. And I think this really encapsulates hernia disease, both before and after surgery. So when you look at, Yeah, can you? So before we even get to the OR, but hernia, sorry, can you click through? We know that abdominal hernias have profound impacts on patients' lives. Besides just the pain and bulging sensation, there's cosmetic concerns. Next. And we know that having a non-approximated midline has a lot of impact on patients' functionality. They have decreased core stability, and studies have linked the presence of ventral hernias to things like back and pelvic pain. Next. And we also know that once you have one hernia, you're likely to have more. How many times have we all gone into the OR and we've gone in for one thing and ended up fixing 4 or 5 or more, especially with incisionals? So I think we really have to start looking at hernia disease in a more complex way. And I think of it a lot like high blood pressure. There's people who take a metoprolol pill and that's all they need for the rest of their lives. There's people who end up on multiple different agents. And so we're fortunate that many, if not most of our hernia patients end up in on the algorithm on the left where they get one repair and then they're done. But I think, sorry, can you click? It's time to start really thinking about the patients who end up in this chronic disease space, either from recurrence or chronic pain or from infection. Surgeons love numbers, so here's some numbers to kind of prove my point. This is the paper that we all look at that talks about the utilization of mesh, is why we support the fact that we put mesh in patients, from the New England Journal in 2000. But when you look at the results, what it actually shows is that, yes, mesh is good, but at 3 years, almost 50% of patients without mesh and 23% of patients with mesh will have some kind of recurrence. Can you click? And if you look out even longer, this is a study from 2004 that looked at 10-year recurrence rates. Click. The recurrence rate at 10 years is even worse. About a third of patients who have mesh repairs end up having a recurrence. So what about umbilical hernias? That's kind of why we're all here today. And not surprisingly, simple umbilical hernias do a lot better. Mesh repairs do still have a 4% recurrence rate, and non-mesh have a 12% recurrence rate. What's important on this slide, though, is think about how many patients actually undergo these procedures. Ventral hernias are one of the most commonly performed elective operations in this country, so even a 4% recurrence rate is a lot of people out there that are having long-term sequelae from these repairs. Next. Besides recurrence, there's other things we have to think about. Chronic pain is something that's very under-researched and poorly understood in this population, but is present in about a third of patients at 2 years and probably worse after this period. Next. Infection, also something that is poorly understood, and we're not really sure why patients get it, but patients need mesh explantation, which can lead to pain not only from the sequelae of the infection itself, but from the mesh explantation. And then there's other issues. And click. Patients need future procedures. Having a mesh in there will make that more complicated and can make that surgery more difficult. There's cosmetic concerns. People don't like the way their abdomens look, either from extra skin or the scar or other things like that. And then there's recurrences that aren't real recurrences. The patients who come back to us with eventration of their mesh, who have a bulging sensation, kind of preperitoneal stuff caught above the repair. These aren't real true recurrences, so they're not really captured by the literature and are probably more prevalent than recurrences themselves. So inguinal hernias, we do a little bit better. The recurrence rate's 2% and 4% for mesh and non-mesh respectively. But chronic pain is something that we look at. And the quoted rate from this Cochrane study is 4% and 6%. I think we all know it's probably higher than that because it's really hard to encapsulate in studies. But this is something that we see long-term in many inguinal hernia patients. And remember, 4 to 6% of inguinal hernia patients, that's a lot of people. Again, there's a lot of people out there that are living with this. So basically what I'm saying is, so ventral hernia patients, we know, exhibit significant long-term sequelae, and it increases over time, both before and after repair. Inguinal hernias can also be a chronic condition, maybe less because of recurrence, although that does happen, but because of chronic pain and other issues. And really, that's just the sequelae that we know about. There's also all of these things that were not really captured, things like quality of life, cosmesis, that sort of thing, that really aren't investigated very well in our current literature. So even patients who have the best outcome likely have altered quality of life due both to preoperative deconditioning and these other sequelae that we're not measuring. So, the most important part of this talk, I think, is what does this mean for us? And I think, you can just click all the way through. I think it's really important that when we counsel our patients, we don't sell it to everybody as a one and done thing. It might be, and that's great. But I think for a lot of patients, especially young patients who have a lot more time to get more procedures, a lot more time to have mesh complications, that sort of thing, we really have to talk about how, this can be something that they will live with in some form for the rest of their life. You really want to avoid burning small bridges, or burning important bridges. Small defects do not need big retromuscular dissections. You want to think about the fact that this person, again, may need an X-lap someday. They might have to go through that retromuscular mesh, and now they're going to have a recurrence from that. And for people who are not optimized, you want to think about that recurrence and who's going to be doing the revisional surgery. If you burn a bridge on an obese smoker, and you do the big retromuscular repair, if that recurs, their options are fairly limited for surgeries going forward. And then, with the emergence of technology, especially the robotic platform, I'm a huge robotic utilizer. I do most of my ab wall stuff on the robot. But it's important to remember that just because you have a robot there, just because you're able to do a robotic ETEP, that doesn't necessarily mean that's the surgery that you should be doing. And you really have to think about what that patient's gonna be like in 5 years, 10 years, 20 years down the road. And the same thing with TARS. High volume abdominal wall surgeons are TARS become kind of bread and butter. It's something we just do. We do both sides. Do we really need to do that? And so when you have a patient in front of you, again, you really want to think about the fact that once you do these dissections, once you enter these planes, it's a permanent alteration to their physiology, and it's something you want to keep in mind. Next. Let me click all the way through. I think this also means looking at your own data very responsibly. It means not just looking at the literature and the quoted recurrence rates, but really looking at your own outcomes. When you do a surgery, what patients are having problems and what problems are they having? And is it something with your patient selection? Is it something with your technique? What can you modify to kind of make this a safer procedure for your patients? And this means looking outside the 30-day window. A lot of times for surgeons, the continuity of care ends at the postoperative visit, and we hope that they do fine after that. We know that patients who have complications often go to a different surgeon. So sometimes it means aggressively following up with people, especially when you're trying new techniques to make sure that your outcomes are what they should be. I think this is actually the most important point, is that we really need to reconceptualize hernia disease as a true disease of the abdominal wall, and it's something that may relapse and remit over the course of a lifetime. It may not. This isn't something we have to go scare patients and say, hey, everyone's going to recur or have problems, but I do really think we have to admit that there is a chronic component to this condition. And, we really can't dismiss patients that have these long-term complaints. We've all seen patients in the office that kind of talk about mesh sensation or pain or alteration of function. And we sort of just say, well, try taking ibuprofen and live with it. We don't really take it seriously some of the time. And I think we really have to admit to ourselves that this is something that is real. It really does impact patients in the long term. And so you have to have really an army of therapies, at the ready to treat these patients. So this is things like thinking outside the box, physical therapy, pain management, even acupuncture has been shown to help some of these patients that have chronic issues. And so I just want to leave this with you. We all know this is true. We've all seen these patients. We've seen patients recur. We blame, the technique, the patient, the this, the that. But I think we all know that in truth, hernia disease really is a chronic thing and something we should be counseling patients with to have a long-term strategy of. Thank you very much for your attention and for your patience with the tech. And I will take any questions later.